Okay, good afternoon. My name is Francine Campbell-Hakim. I am here this afternoon representing the Institute of Caribbean Studies, where we are celebrating World Health Day 2024. And so we know World Health Day was Sunday, and Monday we got preempted by a celestial event. Today was the next best available day for me to bring together this esteemed panel to bring us their messages about health equity and how it impacts them and their industry. To tell you a little bit about myself and how the rest of the afternoon is going to go, my name is Francine Campbell-Hakim. I serve as the Health Futures Group of the Institute of Caribbean Studies. And I try to support the Institute of Caribbean Studies by holding some high-level discussions about health equities, about the futures and issues in the Caribbean region, and also focusing on the Caribbean diaspora, especially in the United States. That's where I live. I have 20 years experience in clinical research. I'm known as a trailblazer for bringing clinical trials into the Caribbean region. I'm known as a lecturer, teacher, and I incorporate storytelling to a lot of my presentations. People say, why you talk a lot? And so that's part of my storytelling history. I bring my experience from clinical research and also projects that I've been able to develop in the Caribbean region, in St. Kitts and Nevis, and also in Jamaica, West Indies. I'm known as a reverse migrationist, meaning that I left the United States to migrate to the Caribbean region, and that's where I raised my children and returned the family to the United States when it was time for them to go to high school. Highly recommend the experience. Um, I have been invited to attend the Summit of the Americas in 2022 and was then donned a civil society participant. I have then since been donned with the civil society participant honor of serving on a United Nations subcommittee for the Civil Society Organization of the United Nations. I'll tell you more about that as it develops. Today, we're coming together and the topic is health equity. To explore this topic, I first started with looking at the global World Health Organization, well, first of all, looking at the World Health Day theme. It says, "My health, my rights." Okay, that's the theme for 2024. My health, my rights. And with that, we're looking at World Health Organization, and they consider health equity the principle that all individuals should have an equal opportunity to attain their highest level of health, regardless of various social determinants. And it remains a critical focus in public health. This panel discussion aims to delve into the multifaceted aspects of health equity, exploring strategies, challenges, and opportunities. And that's what we hope to accomplish this afternoon. I'd like to introduce to you who's on our panel. We have Dr. April Smith-Hirak, and she's representing the Department of Health and Human Services, Region 2, out of New York, New Jersey, Puerto Rico, and the Virgin Islands, if I remember correctly, because I used to work there a long time ago. You were a mere thought in your parents' eyes at that point. I also want to bring to you this afternoon Dr. Denise Johnson. Dr. Johnson is an obstetrician gynecologist through training, a medical physician, and she's going to be speaking from the area of women's health and health equity. We have also Dr. Swinburne Augustine. He is a noted and very highly declarated immunologist, and he's going to bring his aspect of immunology research and health equity. Thank you guys for attending this afternoon. I'm going to be let's go off camera. I'm going to defer the camera to Dr. April Smith, and she has her, okay, so, oh, I forgot the format. So everybody's going to get 3 minutes, and they're going to talk about their aspect of health equity. And then we're going to come together. We're going to come back together. We're going to discuss 5 questions, and we're going to hear responses from each of our panelists. So that is the format for the afternoon. Dr. Smith-Hirak, thank you so much.
Thank you so much. It's really great to be here, both with you, Francine, and with my fellow panelists who are incredibly accomplished. I'm very excited to be speaking with them today. So from the HHS, or Health and Human Services standpoint for the U.S. Department of Health and Human Services, we have a tremendous focus on equity, to the point that health equity is not just a priority, but it is a principle that runs through all of our public health priorities. From where I sit, which covers New York, New Jersey, Puerto Rico, and the USVI, we do a lot of work with island equity. So the Caribbean American Association is very important to us as well. Half of our region is in the Caribbean, and the health equity principles and issues that are happening in island areas are a little bit different than the ones that are happening in the rest of our region in New York and New Jersey. All equally important, just different aspects. HHS overall has an equity action plan, and we have 5 areas that we focus on to advance health equity. It does not encompass everything we do in health equity, but these are the areas that we've chosen to really focus in on and prioritize for the foreseeable immediate future. And these are preventing neglect and improving care to help children thrive in their communities, promoting accessible and welcoming healthcare for all, improving maternal health outcomes for rural, racial, and ethnic minority communities, providing behavioral health for underserved populations, and increasing clinical research and trial diversity that supports innovation. So these are all like very different ways for us to take a look at equity and the ways that public health principles and science go into creating a healthy environment and an equitable environment for all. Within my office, we serve to connect and convene. So Health and Human Services, as you hear from our name, has both health and human services in it. And one of the things that we focus on a lot is marrying and bringing together and coordinating and maximizing the potential impact that can happen when you take the social determinants side, which really often is that human services side of the house, and bring that together with health. Because health doesn't happen in a vacuum. Health happens in our communities and our lives and the places that we live. And so we are always focusing and striving to create environments and communities and support the equitable advancement of all people to achieve their best health. So that's a little bit about what we do. And I'll just share with you one more thing that we have up and coming. It had started out as a resiliency recovery program that was called the ELTRR, which did not trip off of the tongue. So we have rebranded it. It used to be called the long-term resilience and recovery, equitable long-term resilience and recovery plan. And we have rebranded that recently to People and Places Thriving, which makes a lot more sense. But it is really taking ways that we can matrix our governmental and other local and community supports and look at ways to really scaffold and assist all of our communities in creating that resilience and that health and equity. And so I would encourage you also, if you're curious, to take a look at that plan and ways in which different parts of a community can really contribute to helping everyone achieve that health equity that we strive for. Thanks so much. You're on mute.
Thank you so much, Dr. April Smith-Hirak. I noticed that yes, the website talks about even back from in this administration back in 2022, Secretary Xavier Barreca was talking about health equity and coming into the community level. So we're going to come back to questions that you're going to be able to share more information about that. I'm going to move on to Dr. Denise Johnson. There you go. Okay, thank you so much. Oh, I can't wait to hear, because I have real passionate feelings about around women's health and women's health
Great.
equity concerns. I'm trying to be tactful and choose my words carefully. So thank you so much for bringing your message for 3 minutes, and I'm going to start looking at the clock. Okay, go ahead.
Great, thank you. Well, I too am honored to be part of this distinguished panel, and I love that we're focusing on health as a human right. I have been an OBGYN physician, and maternal health is dear to my heart. In my career, I've had the opportunity to view maternal health from several different perspectives. I've seen patients in practice. I've also served in hospital administration and state government. And today, I want to talk about health equity. I want to spend a little time talking about maternal health and mortality, because this is a vital public health concern and it impacts communities globally, certainly here in the US, but also in Latin America and the Caribbean. So annually, thousands of women and birthing individuals around the world are facing severe risks during what should be really the most joyful and exciting times, right? Pregnancy and childbirth. And all across the world, maternal mortality rates increased with the COVID pandemic because it really amplified the fractures that we have in healthcare access. We lost a lot of the gains that were made in the prior years. And even though a new study in the United States suggests that maternal mortality rates might be lower than reported, there's still stark disparities. African American individuals are facing up to 3 times the risk of maternal death. And that's reported in the UK that those gaps are even wider. In the Caribbean, we are seeing these risks more pronounced among those individuals who are economically disadvantaged, indigenous, of African descent, migrants, and those living in rural areas. And these individuals have more significant obstacles in accessing the healthcare that they need. And those obstacles are deeply entrenched in socioeconomic, cultural, and structural inequalities. But most of the maternal deaths are preventable, and they're caused by issues like hemorrhage, hypertension, unsafe abortions, infections. But our systems continue to fail these mothers because of lack of access to healthcare facilities, shortage of skilled professionals, poor quality care, especially in remote areas. But what can we do? So there are regional efforts to decrease these rates, and they're calling on governments and donors and civil societies to come together to invest and prioritize in the health of mothers. And we have to acknowledge that maternal health goes far beyond just being a women's issue. It's a crucial economic and social imperative. The loss of a mother impacts the family's stability, economic productivity, the broader community well-being. And if you enhance maternal health, you can propel progress across all socioeconomic fronts and improve the quality of life and ensure sustainable development. The state of our maternal health mirrors our values as a society. So there's a saying that goes, show me your budget and I'll show you your priorities. So last, I want to say, as an individual provider, there are 4 things that I think that are important for us to do. Number 1, we have to recognize and mitigate our biases. We all have them, and they do influence the outcome for our patients. We need to, number 2, be culturally competent providers. We have to deliver patient-centered care. We have to find out what's important to our patients and let that inform the care that we deliver. Number 3, recognize the importance of the social determinants of health and work with community resources to mitigate. These are things like transportation, insurance, childcare. This is a critical part of care, but it's seldom reimbursed, but it's crucial for good outcomes. And advocate for your patients with policymakers, funders, community groups, etc. Your voice and perspective is important in driving change. And so as we unite today honoring World Health Day, let us reaffirm our dedication and commitment to achieving health as a universal human right. Thank you.
Hey, thank you, Dr. Denise Johnson. Thank you so much. Something that you said that's so dear to me, social determinants of health. What are they? What are they? I looked it up. Economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, okay? Social and community context, okay? I kind of felt taking this 2 minutes to focus on the social determinants of health because they are so important and they run across everything. But you see where it starts with the finances. And then incapacitating the mom affects the whole structure. So yes, thank you so much for your message. Dr. Swinburne Augustine, are you ready to come bring us your 3 minutes? And then we'll come back together after that.
Good afternoon, everyone. Thank you, Francine. And it is an honor to be with Dr. Johnson and Dr. Hirak today to talk about something that's very, very important to all of us, health equity. And when I'll look at it from the research angle, but I want to dive down into the weeds for my understanding of health equity. I'm from Dominica, small island in the Caribbean, and just retired from the United States Environmental Protection Agency as a scientist. When I went home, the village I'm from, when I think of health equity, I'm thinking that everyone in that village should have the same healthcare opportunity that we have here in any county, in any city in the United States. Health equity refers to a state in which everyone has a fair and just opportunity to achieve their highest level of health. To achieve this, we need to address certain critical aspects. One, historical and contemporary injustices. Especially for minorities, we've been left behind, especially in research, and many of the results that we get today are not really applicable to us because a lot of minorities do not participate in the research studies. Francine, you are a clinical researcher, so you would understand that. Overcoming obstacles or efforts should focus on overcoming economic, social, and other barriers to health and healthcare access, eliminating preventable disparities. Dr. Johnson just said a lot of these maternal health problems are preventable. A lot of the problems that we encounter today are preventable. We already talked, Dr. Johnson mentioned the social determinants of health, so I'll go into it, but just looking at the social and community context, which includes factors like discrimination and racism, which affect health outcomes, and that goes into the research field as well, into residencies for minority physicians and scientists. So healthcare access and use, neighborhood and physical environment, workplace conditions, education, which is a big one for me. And some of the strategies before I go into the strategies for improvements on them, income and wealth gaps. Economic stability impacts our health, as we know, and reducing income inequality is a step toward health equity. So if we reduce clinical care inequities, screen for social determinants, broaden our health equity beyond clinical care into the research realm, then I think we will be on our way towards that equity that we're desiring. That's it.
Okay, fantastic. Thank you so much. I'm back here taking notes and I'm thinking about something that you said about you referred to the research component. Yes, there is a disparity in the representation of many communities in the numbers. That's why I took myself to create clinical research opportunities in the Caribbean region, and that went very well until the pandemic happened. So we'll come back talking about that later. We're all on camera now. Let's go to our questions. The first question we're going to be posing, and then we can answer in the same order that we presented. What specific strategies have been effective in reducing health disparities among women, particularly those from marginalized communities? Maybe Denise
Do
should
we want
start.
to go in order or?
No, maybe Denise should start. Go ahead. Thank you,
Well, this
Dr.
is, you can
Johnson,
tell this is my passion, so I had to jump in
gynecologist.
here.
Yes. So yes.
When I was a practicing OBGYN, I had heard about doulas, but I really didn't know much about them. And I think that maybe in my years of practice over a decade, maybe I encountered one or two. But doulas have a great role in helping individuals communicate with the healthcare team, helping to educate them, and causing them to have really much better outcomes. And so that to have a person there who can educate you on what to expect, how to interact with the system, and how to get the resources you need, really makes a huge difference. And it makes a huge difference in addressing those social determinants of health. They really can build a relationship with an individual, find out what they need, and help them get connected, and also give them a better experience by helping them to communicate their needs and their desires to the healthcare team. And so I've become a huge believer in doulas, and that extends to people like community health workers as well. It's really building that relationship and addressing the social determinants of health and providing culturally competent care. So, as we talk about addressing social determinants and providing culturally competent care, those are great models that have done that successfully and have proven improved outcomes.
Fantastic. So we're hearing introduction of the doula paradigm into the management of maternal care. I love that. I love that. We're going to come away with some really great takeaways. I can see it coming now. Okay. Anybody else would like to comment on the with regard to disparities among women, particularly in the marginalized communities?
Yeah, I would love to. So, building even on the doula and taking it maybe even one step further than the doulas in the maternity care, what we see a lot of success with is community health workers, or in some communities, they're called promotoras. And they've been around a really, really long time. But the idea being that somebody from your neighborhood who is the abuela or the expert or whoever it is that everybody turns to, when you employ those folks as community health workers and you give them the educational tools to be able to work with their own communities in a way that really resonates with that community, we see a lot of really great response. And we do get to see things that are maybe communication methods and strategies that would not be what the medical community might have come up with. And yet they are the most effective ways in involving a community in their own care and really helping them to attain better health. And they often will address the social determinants of health, as we were discussing earlier. So that's been a fantastic one. And it often is the women that would benefit from those as well. So even beyond that maternal birth and postpartum care, to involve them in that health in a continuing way with the CHWs, community health workers.
Fantastic. Yes.
So I'm the only male, so one of the things that I would or that I notice when it comes to healthcare disparities for maternal women, I graduated from Meharry Medical College in Nashville. They're all about health disparities, especially for women. And one of the things that affects maternal care is the providers in the area where they are. My wife will search all over Cincinnati to find an OBGYN that looks like her. and it's very hard for a lot of people. So educating the next generation or opening doors for people that look like the people that we're trying to treat, I think is one of the best ways to reach them.
If I could just tag on to that, Dr. Augustine, you're absolutely right. And I think that we've seen numerous studies that say that outcomes are better, right? I think that I was your neighbor. I was at Vanderbilt there in Nashville as well. But we really have seen more renewed efforts, and I know that OASH has been tuned into this as well on recruiting from the communities that we serve. And I think Dr. Hirak mentioned that you know, you get a different level of trust, right? When people are from your community, you don't have to build that trust from the beginning, and it really does help to open up and build those relationships, and it does affect outcomes. So the workforce development in recruiting from the communities that we serve has proven to have benefit, and we just need to continue to do a lot more of it. Yeah, thanks for mentioning that.
Fantastic, fantastic. The common thread that I'm seeing is the community-based level trust initiating relationships. Okay. All right, let's move on to our next question. How can research in immunology contribute to understanding and addressing health disparities, especially in underserved populations?
I guess you want me to take that one. So
yes,
not just immunology, but in every single field. When we design our research studies, we would like to have populations from each of the communities so that when we present the results, they can give us insights into what is happening in each community. And even with clinical trials, how to even dose differently because of what community you come from. And we've had structural problems with research, Tuskegee and all the rest of them, but things have gotten a lot better. COVID-19 showed us a lot how we can work together under very extreme circumstances to come up with cures and to come up with solutions to problems. However, there's a lot of mistrust, and I think one of the biggest things we encounter as scientists is the level of mistrust. Misinformation, especially about vaccines, have become the norm. Measles outbreaks, unheard of measles outbreaks in Florida and other states in the US. Because we're not vaccinating, a person will trust their mechanic more than they trust their physician. And that's a horrible state. I mean, it's really serious that it has come to that. You leave your key with the mechanic, they call you and tell you what they think is wrong with it and how much you're going to pay, and you trust them completely. You just go back, pick up your key, you don't even look at it, you pay and leave. But your health and the people that care and dedicate their lives to taking care of you and to research the things that we don't know, you don't trust them. So we have to build that trust back. During COVID, a lot of people told us, even on TV and radio, they would ask me, well, how can you trust these folks after what they've done? Here's the thing. My only answer was, we are now sitting at the table with them. So we're not going to let them do that to us. So I mean, it's we have to talk to them, and that comes back to the providers, the providers. We have to open up our schools and our best residencies to everyone, so that they can go out and treat their communities.
Okay, thank you so much.
So immunology, with immunology, we are seeing a lot of medications targeting cancer and other diseases through immunology. But we have to participate in those studies to see how, because they may affect us differently while they have a cure for the people who are participating.
Thank you for your comments. That's right. And thank you for what I'm hearing about is making sure that there's a seat at the table where the decisions are being made. Okay. And I totally endorse that and hope to be a part of that or continue to be a part of that in the clinical research area that I have my years experience in. Let me take.
If I can make one quick comment, just to note that I noticed Dr. Oti is on from Communication and Culture, but they have done research on clinical trials hesitancy among African Americans and Asian Americans, and really did focus groups to find out the cause of their hesitancy, and use that research to create messages to help recruit in clinical trials. So so that work is going on, but I think as you said, they need a seat at the table to express what the concerns are, and then we need to take those concerns in terms of crafting messages to help to recruit. But that work is ongoing in many different areas.
Yes, funny, great minds think alike. I was just looking, get ready to say, let me look at the chat, and I see exactly what you just mentioned with regard to the hesitancy and health communications can be, and health communication messages are part of the initial exposure to the idea that there's a problem and that there is a solution. So we're going to speak more about that. Dr. Smith-Hirak, do you have any comments to the question regarding to immunology, contribution, and understanding of addressing health disparities, especially in underserved communities?
My co-panelists have really just hit the nail on the head, and I support all of the things that they said. And I guess the only thing I could really add is that we do know that there are certain immunological conditions that disproportionately affect minority communities, and it is so important that we're able to involve them and partner with those communities in the medical solutions that are going to address the conditions, because creating research based on your, white middle America person is not necessarily going to be an appropriate treatment for a member of that community. And so it's so important to be able to build that trust and to be able to really tailor the solutions to medical conditions and immunological conditions to the communities that are actually suffering from
Yes, they're suffering from the conditions. Okay, so let's go on to one of my next questions, which is, what initiatives or programs have shown promise in reducing racial and ethnic disparities in healthcare access and outcomes, and how can they be scaled or replicated? And this is a tricky question because there's a lot of different things happening right now as we speak that impact achieving those particular health equity parameters or milestones. Okay, let's see who's going to start here. Dr. Who wants to start? Let's see, Dr.
I'll jump in.
Thank you. Thank you.
Sure. Well, I think there are a lot of things happening. Some of the things that we saw during the pandemic is that there was a hold on getting people off of medical assistance, right? And so that people continue to have medical assistance when they would be dropping on, dropping off, and they had continuous access to healthcare. And we significantly improved access to healthcare when we did that. Now that's kind of all being unwound, but that really lifted people up and gave them access where they didn't. We saw Medicaid expansion in many states. Unfortunately, not all states yet, but that Medicaid expansion got people who were really a little above the poverty line but couldn't afford health insurance to get access to insurance and get preventative health care that's costing us a whole lot less money than when we have to pay for their dialysis because they didn't get their diabetes treated, right? We saw Medicaid expansion for postpartum, right? We used to pay for only 6 weeks after delivery, and we know that a lot of mortality and morbidity is happening to a year. And many states have expanded, so giving women access to health care at a longer time after pregnancy, and that has made a big difference. And one other thing I want to mention, there are lots of other initiatives, but many people don't believe that they need DEI training, that they don't need unconscious bias training, but we all have biases. Even in practice, I think that you would think, there's a lot of universal screening that we did. So we screened, it was a big push to screen everyone for domestic violence, right? And so I think the old school physicians would say, oh, she's got a good environment. I'm sure that it's not affecting her. I'm not going to ask this one, I'll ask that one. And we missed a lot of people when we didn't do it universally for absolutely everyone, right? And so we need to check our biases and understand them and mitigate them and make sure that if we see a person come in with high blood pressure, it doesn't matter what their situation is, we need to address that high blood pressure, not to say, well, we'll do it in this one and we do it in the other one. Those biases that we all have, they influence the outcome of our patients. And so we need to recognize them and mitigate them. And I'll pause there. I'm sure that there are lots of other improvements that we've seen that really work.
Yes, yes, there are. There are.
Something
Okay. So back to the question, what initiatives or programs? Dr. April Smith-Hirak, I was hesitating towards you because you probably would know why. Thank you, Dr. Johnson, about the programs and especially from the ground floor level, seeing, the programs work. And I was very encouraged because you had a couple of programs that are working. So I'm encouraged. All right, Dr. Smith-Hirak.
Yeah, I've seen some incredible progress that we've made from a governmental level. We released our class standards. It's been a long time. I think we're even probably due for an update. And I believe the department right now is looking at the way that our class, which is cultural and linguistically appropriate care standards. I think we're even beginning to look at the ways in which class standards are going to need to interact with emerging technologies and how we can mitigate bias in those and provide appropriate care. But what we're seeing and what we have seen is that when organizations implement these class standards, and even up to and including health departments at the state and local level, when they make class standards and how you address class standards to be a condition of the receiving of a grant or any other programming dollars, what we see is that more community organizations are putting thought into that cultural and linguistically appropriate care and communication. And I think the class standards has been, as a policy movement, a really important point for us, and a program that has really resulted in what we like to think of as a trickle-down effect. So when the federal government does have the ability to take that leadership and encourage policies that really do consider what is it, where do you need to meet your patients, or where do you need to meet your community, we do see significant improvements in the ways in which organizations address those issues.
Thank you. Thank you. Yes. Dr. Augustine?
Yes.
Do you know of any programs or initiatives in the research area to look at reducing racial and ethnic disparities?
There are many.
Mhm.
It is, and I'm glad that it's being
Yes.
pervasive. Let's take it from the American Association of Immunology level. Right? There is a big push by a lot of us on committees to get a lot more minorities throughout the organization, from the students that come to the conferences with their mentors all the way up to the president, that they're surrounded with diversity of thought. They really are into it. I will also echo what Dr. Smith-Hirak just said. The government at the EPA, your chances of getting funded for a research project are considerably higher when your project is designed to address a community need for underserved communities, and you have a diverse team to conduct that research. That was something that started under President Obama's administration that is flowing now, and it's I think it's a wonderful thing, because the way we design the projects. One, I have a paper that's just coming out on work that we did with the tribes in Region 6, right? Cherokee Nation in Oklahoma and Choctaw Nation. And we were looking at what was making them sick. Almost all of our illnesses have an environmental, origin. So if we at the EPA are looking at the water, the air, the land where we put people, and study how the environmental impacts affect their health, we can address a lot of the inequities in minority communities, where we live, where we play, where we go to school, where we work. All affect our health, and those are the things that we have to look at on a broad basis. And I think we are getting closer. We still have a lot to go, but we'll keep pushing.
Yes, thank you. I would love to hear more about the work that you're looking at indigenous communities that are and the environment and how it impacts on their health. Yeah, we take different. I think we take sometimes different things for granted about high tension wires in large communities, and find that there's pockets of cancer and those type of examples. One thing I did want to bring up, and I know in the clinical research field that there is a push for developing minority physicians into clinical research aspects. But once you have them developed, you got to get the companies to pick them up. So we're going to be working on that too. I'm going to tell you more about that. Okay. I got lots of stories. Okay. And this is our last question. Then we're going to open up to our audience to see if they have any questions. If they have any questions right now, they can put it in the comments. So when we finish interacting on this last question, we can come to any questions from the audience. Okay, what are the key challenges and opportunities for advancing health equity within the current healthcare system? And what systemic changes are needed to achieve meaningful progress? Okay, so challenges, opportunities, and meaningful progress. Challenges, opportunities.
So if I can jump in, I mean, I've seen this as a state official in state government, but I'm going to talk about it from the provider perspective, and I'll let Dr. Smith-Hirak talk about it from more the governmental or large policy standpoint. But from a individual provider, right, in terms of health equity is the lack of insurance for everyone, right? I mean, so many people don't have insurance or don't have a way to get preventative care, so they end up in a crisis situation that costs us a whole lot more. So there's not a good foundation of what we're talking about here as health as a human right, that everyone has access to healthcare, good quality healthcare, and it's not just a privilege for those who have a good job and have a good health insurance plan. The other thing is that we talked about the social determinants of health being really strong indicators of your health outcome. And so that even if you have the best doctor in the world and you have health insurance, if you don't have a job, or you don't have childcare, or you don't have transportation, you're not going to have the best health outcomes. And the way that we reimburse for healthcare in this country is on an episode basis for your critical illness. And so that all of the other work addressing the social determinants of health, or even finding out what is affecting your patient, none of that's reimbursed, right? There are some demonstration projects that are starting to put reimbursement there, but as a general rule, all that work could ideally be done in the doctor's office or as an extension of that, but there's no funding for it. And so there's no real way for practices to be able to do that work. And that work is probably more important in your outcomes than anything that the doctor can do. And I'll stop there.
Okay.
I'll go on and add to Dr. Johnson. I completely agree with what she's saying. And I think that for me, it's the way that our system in the US is structured is truly a sick care system rather than a well care system. And as a public health practitioner, you know, public health is on the opposite side. We want everybody to be well, and then we don't have the sickness, and we avoid some of the chronic conditions and other things that really disproportionately affect minority communities, underserved communities. And the way that I have been focusing on this over the last several years is really looking at the ways in which emerging technologies are being used as tools in our system. And I think that some of these emerging digital and genetic and other molecular health technologies are developing are going to be crucial in the way that we're able to deliver equitable care to communities. And so when we spoke earlier about the importance of involving minority and underserved communities in research and in design is really important. I've seen some incredible applications. Just last month at the HIMSS conference, I saw a large hospital system in my network present on a way in which they used an AI algorithm to queue in patients that may be experiencing difficulties related to social determinants of health in their system. It was fed into their EMRs, created alerts with physicians, and created an opportunity for a physician to have a conversation about what those social determinants were and ask the patients if they wanted to participate in a program that was then directed towards community health workers. And the ones that opted in and chose to participate had their social determinants of health met through these community health workers who helped them navigate access to systems and resources. And what they saw was, I think it was something like a $40 million savings to the healthcare system just from this one small pilot. And for healthcare systems, that dollar amount is really important. For public health practitioners and doctors, and those of us who are caring with patients every single day and communities every single day, what we see from that benefit is not the dollar amount, but it's the improvement in health status. And so these are ways in which we can direct emerging technologies rather than continuing to disadvantaged populations. We can use those technologies to increase the ability for those populations to be helpful for all.
I like that. I like that that study, that pilot. That's very helpful. That's something that could be replicated also. So, Dr. Augustine, any comments?
Yes, a little bit.
Challenges and opportunities for advancing.
So achieving health equity requires a collective, collaborative effort from community organizations, healthcare systems, policymakers, public health agencies, all working together. But a critical component of that whole collaboration, especially on the research side, is involving the community. What we noticed in the past few years when we designed research projects, we had something called citizen science. They've changed it now to participation science, where we go into the communities and recruit people from there and have them participate in the research itself. They get updates on the data. They get they can pull out at any time, as any research participant can. But by educating our publics, our communities, and sending, there are lots of us who are willing to go, right? Send us to go talk to them, because a lot of us have similar experiences. And the person is more likely to listen to someone who has a similar experience than someone they think is talking down to them. So if we can do that, get the community, the people themselves involved, let them understand what that research study is for. Say sickle cell, because sickle cell affects a lot of African Americans. How can we get better or get towards a cure if we are not participating in the research programs to find a cure? It is for us. So we have to start encouraging and educating our communities to at least trust the system a bit, yes. And it takes people like us who've been in it to pass that message on to them.
Yes, Dr. Augustine, you said a couple of things this afternoon I wanted to, when you said that we trust our mechanic more than our doctor, I had to drop my head, but in all actuality, I did raise my head back up and I thought about it, and there's some validity to that. And I think that I'm hearing, if we want to summarize a couple of things, I'm hearing health messages, I'm hearing community-based, right at the root, community-based efforts, and building a lot from the community level to create the equitable experiences. Let's see. I'm going to ask a question. Right now, when we're talking so much about DE&I, diversity, equity, and inclusion, why are we seeing these programs? Have we met the objectives? Is that why the programs are waning? Or do they feel the programs are maybe not effective? And maybe that's an unfair question to pose, because I haven't really prompted you guys for that. But I was thinking about equity and health. We want to make sure that there's equity in health. But what we're seeing is that there's social determinants of health, which also include financial stability. So, and then now we're changing are we changing the objectives? Does anybody know what's happening with that? Any takers?
So just from my perspective, I think that there is a lack of full understanding what DEI is. And I think that there's an assumption and a spreading of misinformation that what it is doing, it is taking away the advantage of some and giving it to some that is undeserved. So I think that unless we have real honest conversations about what it is and it isn't, as Dr. Augustine talked about, especially during the COVID era, there's a lot of misinformation that spread. And once that's spread and people take hold of it, it's really hard to get to the truth. And so I think people don't quite understand it. I think it's just feeling that some benefit that we already have is going to be taken away and given to someone that is undeserving in their eyes. Just my perspective.
Fantastic. We see a question that's popped up in the chat. How will AI affect the healthcare system regarding diminishing disparities, especially in rural communities? Thank you for that question. And Dr. Who can answer that? I know Dr. Smith was given a fine example of that. I would love to see that replicated. That's the AI with screening through the medical record system and tagging and flagging the physician. And also there should be training for the physician on how to approach the patient for exploring around social determinants of health. Is anybody else?
So
Dr.
I can
Dr.
take a stab at that.
Fantastic, thanks.
Artificial intelligence, especially in research, is starting to, and in healthcare, it's starting to make a lot of things easier. Information, the access to information quick. However, the algorithms, the very foundation that's building the artificial intelligence, we have to address all the same systemic biases in them. Otherwise, the results are going to be the same. So just like we address biases in our physical world, we have to do that in the digital world as well, in the way that we design these algorithms. Now, you asked whether DEI, it seems like there is a certain political environment, and I'm going to address it. I retired now. So there's a certain political environment here in the United States that wants to get rid of anything DEI. It doesn't make sense, right? I mean, like Dr. Johnson said, it's not a matter of taking from one to give to another. That's not what's happening. What is happening is that if Dr. Johnson and I and Dr. Smith-Hirak apply for a job, they look at the qualifications and nothing else. Not how we look, not how we, and that affects a whole lot of things. Healthcare, like we said, education and opportunities to address those social determinants of health.
Absolutely.
Right? So you have to give opportunities to people so they don't feel like they're still on a plantation.
True.
And with that,
fantastic. Thank you for. So we've come to 1 hour of our dialogue, and I wanted to, Dr. April Smith-Hirak had to drop off for a 1:30 appointment. And so we're going to be closing our panel discussion. I want to thank each of you and also Dr. Smith-Hirak for spending your afternoon to share with us your thoughts on health equity and to celebrate World Health Day 2024. My name is Francine Campbell-Hakim, and we're going to close off our recording. Okay.
Thank you very much. Nice to meet you, Dr. Augustine.
Bye. Same here.
Okay, bye, guys.
Bye.
All right. Okay. Stop recording. Oh, yeah.